received the page. This is Dr. Acquah, medical resident. Okay, I'll be coming downstairs shortly to evaluate the patient, okay? All right, thank you. All right, so I just got a call from the anesthesiologist. There was a patient, elderly patient that came here after a fall, and patient injured a hip. They took the patient to the OR. They did a right hip hemiarthroplasty. They fixed the hip, but patient was intubated before the surgery, and now they're having difficulty taking the tube out, meaning extubating the patient. Aside from that, patient also has a low blood pressure. They gave some fluids, but the blood pressure is still low. So the patient will require a medication to help hold the blood pressure up. We call that pressor. He did mention that he had already started patient on norepinephrine, which is one of the pressors available that we use. Since I'm in the ICU, I have to go downstairs to PACU, evaluate the patient, and bring the patient up to the ICU and take care of the patient. Hopefully we can figure out exactly what could be going on. All right, so this is the case. All right, let's do it. Being in the ICU is very tiring. As you can see, I'm not wearing the same scrubs as I was when I had initially started recording. A lot of things transpired after I went to see that patient. But if you're new here, my name is Dr. Frederick Acquah. Currently, I'm a third-year internal medicine chief resident in New Jersey. On this platform, we talk on faith, principles, and medicine. So be sure to subscribe, okay? And don't forget to like this video. All right, so I'll go on with, I may have to change the trajectory of this video. I'll go ahead and talk to you guys about code status and something else. So when it comes to code status, what I would recommend to you as a parent or to you as a child of an older parent, the main thing that we need to work on is code status. What do I mean by that? If you had watched my video on day in the life of a resident in a hospital, I'm going to leave the link in the video. It should be up here. Part of that video, you would hear me talking about code status. So in this video, I'll explore more into it. So anytime someone comes to the hospital and we admit a patient, a question we do ask, which is a routine question to most patients, is, what happens, God forbid, in case a nurse walks in the room and finds that your heart is not beating? At that point in time, what do you want us to do? Do we start chest compressions, or do we not do that? And also, God forbid, in case you're in a hospital and your breathing worsens, what exactly do you want us to do? Are we going all the way to the extent that we'll have to intubate you? Meaning, there's this tube-like device that we put down someone's throat, connect that tube-like device to a machine called a ventilator, and then that breathes for the patient. While you're intubated, of course, we'll have to put you on sedation, something to sedate you so you don't fight the vent. We have to give you pain medications. We call it analgesics. So you're not in pain while having that tube down your throat. Every patient that comes to the hospital, we also recommend that you know exactly whom you're choosing to make medical decisions for you in case you cannot do it. Anything can happen in a hospital. So in case you cannot make that decision, you need to discuss what you would want to be done to you medically while you're in the hospital. So at least someone in the family need to answer those questions in case it gets to that point. Now, there are some patients that will come, they do not have that code status, and we may have to go through this path of whom we call for decision-making hierarchy. First of all, we go to the patient's spouse, if the patient is married, unless patient is legally separated. The next person that we can get in touch with, if we cannot get the first person, will be the adult child of the parent. The next person is a domestic partner. Then it goes to the siblings of the patient, then a close friend, and then the attending physician with ethics committee can be consulted to make that decision for the patient. But the main thing here is that the patient or the sick person in the hospital needs to have made all these decisions earlier on. When you're having conversations with family and friends, the goal here is to also discuss what you would want done to you in case you are in a certain situation. If it was me, I want things done to me a certain way. So what do? I have to discuss with my wife, and as my kids grow, I'll discuss with them what I would want to be done to me, because I don't want them trying to sustain my life in situations where I wouldn't want that happening. I wouldn't want that happening to me. Every family member wants to keep their relatives alive, but sometimes that's not what the relative wants to be done to him or her. Everyone in the medical field needs to be trained when it comes to the code status, as in if patient opts to get chest compressions done, or if patient has a cardiac arrest and we have to intervene and do CPR, we all need to get certified. And I would say the best gift that you can give a family member this year or the years to come is if you can get trained or if you can get certified in BLS. It's a good thing for you to be outside, someone has a cardiac arrest, and you intervene and start CPR even before EMTs and the paramedics arrive. There's American Heart Association website. There's an algorithm I was talking about. And as you can see, like I mentioned, internal medicine, we take care of people 18 years and older. The main thing that we have to do here is to start chest compressions, which is the CPR. While doing that, we connect the monitor to the patient. There are two things we're looking for, whether we have a shockable rhythm or not. And this is why I did explain that I see running a code as two separate things, right? You have the asystole, which is a flat line, and PEA, pulseless electrical activity, or you have the ventricular tachycardia or ventricular fibrillation. Now, if it's ventricular tachycardia, ventricular fibrillation, most likely we are to give a patient a shock. And you can see this in most medical drama series on TV, where someone in cardiac arrest get shocked. Most of the time, the patient may be in this rhythm. Or if it's a systole or PEA, we do not give a shock. We start as soon as possible. We need to give epinephrine while CPR is going on. So CPR goes on for 2 minutes. We hold a CPR. We do pulse check, rhythm check, shock if indicated. If no shock is indicated, then we continue the CPR. So we are required to run this code with the goal of reviving the patient. We cannot revive every patient during a code. There are some who have significant comorbidities that makes it very difficult for us to revive during the code. But we do everything we can in our power, give as much medications as we can based on the protocol to revive a patient. So just going back to the earlier case I had discussed, the reason why I couldn't record was that there were a lot of codes going on in the hospital generally. So I was busy, and for that patient coded 3 times, and fortunately the family were able to come to the hospital late at night, and they switched his code status to do not resuscitate. So when patient had another cardiac arrest, we did not intervene, and the family allowed the patient to pass peacefully. I will end this video here. I'm being paged again, so I have to go. I'm doing ICU nights. It's busy out here, so please stay out of the ICU. Don't get sick. Stay out of trouble. We'll see you guys in my next video. Shalom. Basic life support and advanced cardiovascular care support.
For bed 4. They're making me redraw my last week for time because they're telling me there's diabetes.
Okay.
And they can't reorder that.
Okay, let's take a look at this. So here